So now it's a smaller group. Lisa's one of my friends. No, Lisa is the past president of Society of Back Pain Research. She's a professor at Southampton and somehow maintains a busy clinical consultancy as a physiotherapist as well as an academic professorial appointment. She's very closely involved with BritSpine. I haven't for many years looked at her biography, so I'm not sure exactly what I will have missed out, but certainly she's a very esteemed speaker, and we're delighted to welcome her to BritSpine on behalf of the Society of Back Pain Research. Professor Lisa Roberts.
Thank you, and thank you to BritSpine and to the Society for Back Pain Research for inviting me to be here today, and a huge thank you to all of you for coming on the last afternoon of the conference, and I know it's been a busy lunchtime. So, as Steve said, I'm a clinical professor, a physiotherapist by background, and for the last 15 years have been researching communication in back pain consultations. And it's my absolute pleasure to be talking about the important and I would say incredibly challenging topic of self-management. And I hope it'll build on what Alf said yesterday. But before we start, I'd like you to think about your own practice. And in a consultational care episode, at what point do you discuss self-management strategies with patients? And let's be honest, how good are you at it? If we were to go out and ask a group of your patients to score you out of 10, how good or how confident they feel with your self-management, I wonder what they would say. And when you do it, what do you actually do or say? And these are really good reflections to have afterwards. And I hope some of you will have some CPD training sessions or in-service sessions with your teams, really drilling down into this stuff. So what I'm going to cover is a little bit about what is self-management and why does it matter. I was asked to cover the evidence base and whether patients actually want more support to self-manage. And then we're going to look at the components of self-management and some top tips to help build on the skills that you've already got so that you could put this into practice if you're lucky enough to be in clinic tomorrow or next week. So if we go to our guidelines and pathways call us to promote self-management. Well, what exactly are we asked to do? If you look at NICE from 2016, it talks about providing people with advice and information that's tailored to their needs and capabilities, and it seems to include information on the nature of low back pain and sciatica and encouragement to continue with normal activity. Not exactly challenging for a clinician when you look at it like that. If you look at the pathway, it goes a bit further, looking at GP or over-the-counter medication, self-directed exercises, relaxation, and returning to normal social and occupational activity. So a bit more direction with that. So why do we need supported self-management? Well, partly because of the evolving evidence base, but particularly because our services are completely overwhelmed. And I looked at these statistics. Now, these are people with long-term conditions. It's not just back pain. But we know that people with long-term conditions, and this data was pre-COVID, were responsible for using 52% of all GP appointments, 65% of outpatients, 72% of inpatient days, and nearly 70% of NHS spending in primary and hospital care. So this is a perfect storm. We've got rising rates of chronic illness, we've got significant and economic burden, but at the heart of this, we've got patients who are really struggling and distressed and really fighting their way through systems, and we all know the challenges of that. Now, in 2019, Versus Arthritis estimated that there are 10 million people in the UK with back pain, and we've got to remember that they self-manage their symptoms most of the time. But up to 20% of those are managing more or less continuously their symptoms. So clearly the system's not working, and we know from NHS Digital in 2020 that there are 50,000 emergency appointment attendances each month. And no, that's not a mistake. That is each month in the UK for back pain. So we know that demand is far exceeding capacity, and we know it's clearly not sustainable. So this is where self-management comes in. But I want to use the word supported self-management, and we'll come back to that. Now, it might surprise you that there's no universal definition, and for the purposes of this talk, I'm talking about tailored interventions and approaches that help people develop knowledge, skills, and confidence to make positive choices And I've underlined the bit about proactively making necessary changes to health behaviour. These are health behaviour interventions, and to manage the long-term impact of their condition. So it's way more than patient education. And we're moving away from these sort of professionally driven treatment plans and goals. And instead, really focusing, instead of what's the matter with you, to what matters to you. Now, among clinicians and within the literature, there's lots of terms that are used interchangeably, things like self-care, self-management, self-efficacy, symptom management, without clear definitions and without thinking about the underlying theory. And if we think about self-care, that's all the actions that people do to help themselves stay healthy. So it might be brushing your teeth, it might be not drinking too much, although we all know what happens at BritSpine, and perhaps eating healthily and so on. Whereas self-management is the part of self-care that relates to dealing with a health condition. And what we're trying to do is get patients to be active participants and take responsibility for functioning optimally. We've also then got obviously the symptom management, which might be interventions by the patient or the clinician or both to try and decrease the distress and consequence of the symptoms. And then all of this is really bound up in self-efficacy, which is people's belief in their ability to be able to influence their own lives. So what are we doing here? What we want is for people to realise they're not alone, that they are not managing without healthcare. What we're trying to do is empower them so they know when to consult. When do they need diagnostic assessment? When do they need symptom relief? And when do they need advice? And that's what supported self-management is really all about. Now, in order to help patients change behaviour, which is what we're all trying to do, it's essential to understand their beliefs and their behaviours or their lack of health behaviours. What's actually driving all of this? And Kelly and Barker in 2016 said how important it is to not make assumptions. And what you commonly see are the assumptions that behaviour change is common sense. Not necessarily. That knowledge and information drive behaviour. You might think they do, but the evidence is they don't necessarily. That people act rationally and irrationally, and also that it's not actually possible to predict behaviour accurately. And this is where communication comes in, because it's absolutely key to finding out about a person's healthy lifestyle. But you want to do it in a way that encourages them to be honest, and they're not just telling you what they think you want to hear, and then you get all that social desirability bias. And we know from the literature that just telling people really doesn't work. When people are more disabled with their low back pain, they perceive their condition as more frightening, they're out of control. We know that they have then low self-efficacy. And there's a whole plethora of different models to help us think about behaviour change. And what is known is that the interventions that are developed or delivered with a theoretical foundation are more effective than those without. Now, I'm just going to touch on one very old theory now, the trans-theoretical model, which was developed by James Prochaska and Carlo Di Clementi in the 1970s. And this, why I've put this up is this shows the importance of a staged model of behaviour change. Now, it was originally developed to look at why some people were able to quit smoking and others weren't. And what they identified through all of this was that there were stages of behaviour change. There are actually 6 stages. The pre-contemplation stage, where the person has no intention of taking any action. We've probably all had patients like that. We've probably all been like that at times in our lives. Then there's the contemplation, which is when people are thinking about it and think something might be happening in the next 6 months. The preparation is when it's within the next month. The action stage is thought to take about 6 months when they are doing something. Maintaining it is keeping it going more than the 6 months, and eventually reaching the point of termination when they've achieved that behaviour change and they're not going to relapse. Now, why am I even mentioning this? Why I'm mentioning it is when you're talking with patients, it's really important to think about what stage is that person at? Are they ready for change? And it may be, for example, in the first 2 or 3 stages that they need more information and education. Whereas in the later stages, your approach might be much more around providing reassurance and positive feedback. So that's really important to think about. And if you want some good resources on reassurance, can I strongly recommend the work of Tamar Pincus. If you haven't seen this work, it's well worth a look. the team identified two different types of reassurance. There's the affective or emotional reassurance, which is about creating rapport and empathy. And then there's the cognitive and informational reassurance, which is about providing explanations and education. And they're doing very different things. In a systematic review in pain in 2013, they reported that giving information, so working on this cognitive domain, is really key in identifying and helping patients address concerns about their pain. That may be very helpful when you're having some discussions about their expectations. And that's been shown that that is really helpful for impacting outcome. Whereas the affective reassurance is particularly helpful when looking at patients' experience. So if you want to impact a positive outcome and a good patient experience, then it's really important to think about addressing both of those things, cognitively and affectively. So if we look at the evidence for underpinning self-management, I've put it into three groups of benefits for the patient, for the clinician, and for the service. We know for patients that there are significant gains in health status. They have a better quality of life, better outcomes, and positive impacts on their attitudes. We know for the clinicians that they have more meaningful conversations with patients, which has greater impact and increases satisfaction. And for the service, we know it reduces use of GP time, hospital admissions, services are more joined up and more cost effective. But people often think, well, do patients really want this stuff? And actually, I can't find a more updated poll in a similar way. This was in 2005 from Mori, where they found that 82% of patients already play an active role, but would like to do more. More than 90% were interested in becoming more active self-carers, and I imagine that's probably gone up since COVID. And more than 75% said that if they had more guidance and support, they would feel more confident about taking care of their health. So here we've got a massive call for helping people build confidence. However, at the same time, what we've got is from the National NHS patient surveys that were carried out by the Care Quality Commission, 40% of patients said they'd not been given any written information about what they should or shouldn't be doing after they leave hospital. And 25% of people with a long-term condition said they didn't receive enough support from their local services to self-manage their condition. So we've got this mismatch between what the patients are reporting to want and what the services are actually delivering. So having had a look at the evidence, let's have a look at what do we do in practice. And Lorig and Holman categorised self-management into these 5 stages. It's about problem solving, decision making, resource utilisation, forming that really important partnership and taking action. Now, they all promote self-efficacy, and what I really want to emphasise is this doesn't belong to any one profession. People often think, yeah, go and see the physio, they do self-management. Every single health professional should be doing self-management and supporting patients with it. It doesn't belong to any single profession. Now, rather frustratingly, there's no clear evidence showing exactly how the most effective self-management takes place. But Kongstead, this is a very good article, talked about the importance of autonomy, self-efficacy, and a healthy lifestyle, and about letting patient value goals, and that actually driving their behavioural change, and that will direct management. If they buy into these goals that they've set, they're much more likely to see them through. So we've got to think about what stage is the patient at, and remember that stepped model. And we need to shift the focus away from structure and pain and impairment, and instead be thinking about problem-solving skills, giving patients insight and tools to help manage these symptoms so that they're going to get, again, an encounter in everyday life. And we all see patients where, they are confusing sensation of symptoms with some catastrophic damage that's happening. So it's preparing them that you will still get your pain and discomfort. How are you going to live with it? And that's really important for building up those successful experiences. And I really want to call out here the importance of how we teach or encourage people with home exercises. And this is one particularly for the physios among us. There's very, very little evidence to support that the way an exercise is done absolutely affects its outcome. Does it matter whether their leg is at 20 degrees or 30 degrees or 50 degrees? And if we keep correcting these exercises, it runs a risk of actually decreasing a person's self-management skills, because what we're communicating is this exercise is difficult and it's potentially unsafe to do on your own. Instead, let's celebrate, God, they're actually doing something. You know, let's make it even better, but not nitpicking of, well, you need to do this, you need to do that, you need to do the other. What we're doing by correcting, we might think we're making it even better, but we might be encouraging the patients to lose that autonomy and that self-efficacy, and we actually make them more fearful of doing something wrong and even harming themselves. So really have a think about your practice and how you feed back to patients when you're helping them sort out some exercises to do. We also need to think about other things that can help manage pain and emotions, and it's things like mindfulness, breathing exercises, all of those things that we've heard so much about, but particularly it's the graded exposure. You know, what activities are they avoiding and why are they avoiding them, and how can we help them start to get back doing those? We want to evaluate progress, adjust the goals and make an action plan for dealing with these future challenges and relapses that they will have. Last year, Nathan Hutting, myself and a group of us developed and published this self-management identification tool. And when you look at it, perhaps it's no wonder that we all struggle with the whole construct of self-management. It's really complex. But I want to really focus on two things right at the heart of it, which is around goal setting and making decisions. And I want to really touch on, and I know I've talked a little bit about this goal-orientated approach, which can be really helpful for patients with complex needs. This was empirical work that was done by Vermont, and it led to a 3-level model for goal setting. And patients often come to us wanting help with disease or symptom-specific goals. It might be functional goals, like they can't walk up the stairs or whatever it is. But then there's this really important one called fundamental goals, which draw on people's hopes and values and priorities in life. Now, these are often less clearly defined, are much more important, and actually guide the patient's priority. And this is going to be uncomfortable for some of us, but the recommendation is that we start with the fundamental goals, because these will drive the function and the symptom-specific goals. And in 2020, Elwyn and Vermont published this goal-based shared decision-making model based on those steps that Alf talked about of team talk, option talk, and decision talk. So the team talk is that partnership between the clinician and the patient. And again, recommending those goals at all 3 levels, but start with the fundamental. So for example, I've recently been treating a patient who's got hip dysplasia, been diagnosed with functional neurological disorder, and had a pretty torrid time. And when I first met her, she was very angry and demanded that she needed a wheelchair. And it was quite a difficult consultation because she had had really a lot of difficulties with some of my colleagues. And when we started with fundamental goals, what she really wants out of life is to move out of the damp, hideous circumstances in which she's living. And she wants to move in with her boyfriend. So we started from a point of, okay, if that's the goal, you want to move in with your boyfriend, what do we need to get there? And does a wheelchair help? And so it's been a really different way of handling a consultation, but immediately she's calmed down, she's not shouting, she's actually really engaged in doing stuff. And I think a huge part of that was because she set her goals. So having identified some goals, the next step, the option talk, is prioritising them, look at your risks, benefits, alternatives, and then think about making that decision together. And all of this requires advanced communication skills. And sadly, as health professionals, we're perhaps not quite as good as we like to think we are. And in some of our early research, we were looking at the communication that takes place in primary care consultations between clinicians and patients with back pain. And we were looking specifically at how decisions are made. Who makes the decisions? Who thinks they make the decisions? And how does all that happen? And we chose to use the option scale by Elwyn and colleagues. And it's an absolutely fantastic scale that was initially developed to rate general practice consultations, but it's got generic phrasing that can be applied to any clinical setting. And basically, there are 12 behaviours that are not rocket science. They're things like, have you explained the pros and cons of treatment options? Have you explored patients' concerns and beliefs? Have you given an option of no treatment? And you score each of those behaviours on that scale of 0 to 4. So 0 is it doesn't happen, and 4, it happens at a very high level. Sum up all the 12 behaviours, turn the handle, get yourself a percentage. And the really important bit is the authors of this scale determined that 60% is generally accepted as the minimum level of competence for good shared decision-making practice. Now, we did a longitudinal study. We had 12 clinicians. We had 78 encounters. 40 of them were first contacts, 38 were follow-ups. And these felt really positive interactions. I sat through all of them. Patients were really engaged. And when we scored afterwards against the option scale, the mean was 24%. The range was 10 to 44. Nobody was anywhere near the 60% competence. And we published this nearly a decade ago now in the European Spine Journal. And it's a great fun task. If you're able to, with patients' permission, audio record your consultations, you can easily score yourself and see if you're anywhere near 60%. And it makes for a really interesting CPD and in-service training discussion. Okay, so we've talked about communication, and Weatherall described it as the most important aspect that health professionals have to master. And we know that these skills have been identified in the literature as making a positive difference. We know that providing explanations of chronic low back pain legitimizes the patient's experience and downgrades that perceived threat. That's such an important thing. And any surgeons among you, my God, you've got so much clout when you do that, that the patients will hang on to every word you say. The information needs to be easily accessible, structured, up-to-date and accurate, and really tailored to that individual. In our earlier support-backed randomised controlled trial of web-based interventions, reassurance and ongoing support to implement behaviour change was key. And using symptomatology, prior knowledge and experience, your patient is an expert in their own body, and how much of that can you harness, which will save you a lot of time in clinic. What we need to do on the negative side is avoid directing people to resources where there are inappropriate messages and rubbish wording, things like wear and tear, or things like discs popping out, or saying to patients what you're allowed to do. All of this stuff is really eroding that self-efficacy and that autonomy that we're trying to build. And I also just wanted to mention the notion of fluctuating uncertainty, which is when patients have self-doubt and this loss of identity, and that really impacts on their self-efficacy, where they perceive pain as a threat. And I want to talk about Bork's work, because this fluctuating nature of chronic low back pain means that pain resilience is often replaced by this returning of self-doubt. And Bork did a qualitative study of individuals attending an outpatient physical therapy department, and the individuals developed pain resilience by downgrading the perceived effects of chronic pain. So again, you can see how important that reassurance really is. And it's so important to choose your words carefully, even simple phrases like, "It's up to you." That might give them an element of choice. If you say to somebody, "Well, it's down to you," that might be empowering for some people, but it might feel like a heavy burden for others. "It's over to you," that might be a positive handover. Now it's your turn. Or, if not done well, it might be a sense of feeling abandoned. So the context is key, and it's trying to empathise and get that right. And no wonder we find this stuff difficult. So evidence is growing fast, and we need to address the changing needs of the population. And National Voices summarise the evidence from 228 systematic reviews published between 1998 and 2013 on the best research evidence about supporting self-management, and found the top things that you could do was providing that condition-specific education and integrating that into routine care. Now, we haven't all got time for that, so actually, what sites can you identify? What resources have you got? How can we share things? Eurospine has loads of patient information leaflets. BAS has stuff. There's loads of things out there from the Chartered Society of Physiotherapy, from Versus Arthritis, all of these places that you can direct patients to. It's great if you are able to be involved with educational courses that might involve or be read and run by lay people. Interactive online self-management programs, telephone support, telehealth initiatives. I occasionally have emails with my patients, and I don't bring them in for consultations. We just manage a few things by email, and that seems to work really well. And self-monitoring of medication and symptoms as well. So this whole contemporary approach to self-management is now embracing flexibility and tailoring so that we've got combinations of strategies. And I think the really important thing here is one size doesn't fit all. So there is a continuum of strategies, and then basically the multifaceted ones have been shown to be more effective than ones that just focus on education and building confidence alone. So what do we know about outcomes? Well, despite the growth of research in this area over the last decade, the optimal content and mechanisms of change still remain unclear. We know there's loads of homogeneity in subgroups of back pain, but when you look at the trials, we've got huge heterogeneity, and particularly around self-management. There's generally low to moderate methodological quality, and most interventions are really not well described. They're a mishmash of all sorts of things. What we know is there's hundreds, literally, of smartphone apps that are related to back pain, and a lot of those have been developed with very little science and even less rigour. And what I think is a missed opportunity here is that clinical outcomes always seem to be about pain intensity and back-related disability. But here we are talking about getting patients to change behaviour. And so why are our outcomes not around self-management skills, learning, knowledge, and relate them to the goals that we're trying to get people to achieve? We don't have valid measurement tools to capture the complexity of back pain management. And there is this lack of evidence to say whether or not it's best done individually or in a group. What we do know is if people have other comorbidities like COPD or stroke, or if they perceive their back symptoms to be more severe, they don't do as well. On the positive side, what we do know is there's small to moderate effects on key clinical outcomes, which are back pain intensity and disability, and self-efficacy, and these are for at least up to a year post-intervention. We know that shorter interventions, and by that they're usually 1 to 6 weeks, they're certainly less than 8 weeks, are more effective than longer-lasting ones. We know that where the whole or some of the intervention is delivered on the internet or an e-platform, it's as effective as in person. And we know that when people do it over a mobile phone, it's actually better than when you do it on the internet, although they haven't been directly compared. So, to draw this session together, here are the take-home messages. First of all, we need to determine how best to support behavioural self-management for people with low back pain. It's a priority. It needs more research, it needs more funding. It's not funded easily because it's difficult to measure. We need to consider the stages that the patient's out of behaviour change. How ready are they to make these changes? Think about starting with fundamental goals. Pick your most challenging patients. Try and see how you get on. It's been a real eye-opener for me. And investing time in further enhancing your communication skills. And I really encourage you to look at shared decision-making and reassurance. And remember that the power of communication has the potential to improve the outcome and experience of every single care episode that you have. And that is more important than any single treatments that we offer, because nothing else affects everything that we do. And so, without any further ado, it's now over to you. Thank you.
Thank you very much, Lisa. We've probably just got time for a couple of questions. Yeah, please do take the mic.
Hi, Prajay Gulash here. Very nice presentation.
Thank
I think
you.
I did the right thing missing the cervical deformity and come over here.
I couldn't possibly comment.
Two things, if I can. A, how do you, the patient is not ready for change. They'll come with a fixed mind to you in your clinic.
Yeah.
There was a report of the scan said, this is what I want.
Yeah.
How do you practically enforce, or not enforce the right word, but stimulate that change? And I'll come to the second question.
Okay, great question, thank you. Certainly, I think the important thing is you're listening to what they're saying, and if they're absolutely not ready for change, then it's about the options, putting forward, we could do this option, we could do that option, we could do nothing, we could wait. What are your thoughts about that? And it's so rare that health professionals say doing nothing. Now, doing nothing might be waiting, but you're still giving them the option, look, I'll sometimes say to my patients, look, you've got an awful lot going on at the moment. We don't have to do anything now. This is entirely up to you. Do you want to start some treatment? Would you rather wait? Or would you rather go off and, we explore whatever else it is that they want to do? And I think, again, quite often people say, look, this really isn't the right time. Can I leave it a month or two? And I'm like, that's absolutely fine. And so leaving them the option of then they get back in touch, or sometimes I'll say to people, do you want to go and book yourself in 3 months' time? And it's about having that discussion of when is the right time, because I think there's no point, unless obviously something clinically will deteriorate and you've only got a narrow window. I'm not talking about those patients. But people with persistent pain who've got so much else going on in their lives, is it a good use of their time And is it a good use of your time if they're not going to engage in anything that you're offering? And actually, it would be much better to wait until whatever crisis is over and then they come back. So it's that choice, and really, you know, giving them a genuine option of we don't have to do anything now. And it's surprising how many people say, do you know what, I'd rather leave it.
Yeah, thank you so much. I think the way you say it is important.
I'm sorry, because we're out of time.
Okay, just a second
And the
question.
other gentleman was, I was just going to invite
Alex,
the...
I'll give Alex.
Okay. Oh, yeah, no, go.
All right. The
Quick question.
Very quick question.
Because we are out
The
of time.
wear and tear, you know, what's wrong in saying you've got normal wear and tear that you expect?
Wear and tear is a difficult one because tearing implies damage. And if you say to somebody, what do you think is actually torn? Oh, well, my disc is torn and this and this and this. Okay, yeah, it might be, you know, to all our purposes, if we look at it, it's got degenerative change. But is that a helpful construct? Because then, you know, in that classic moment when you say to a patient, well, you've got chronic low back pain, in daily language, chronic means dire. You've got some wear and tear, something's torn, and we'd really like you to be active. Hang on, this is dire, something's torn, and you want me to exercise? So you're putting barriers there that don't need to be there. And that's why I would really encourage people to think about wear and tear. Wear, it's all right, tearing is just the concept of something actually being really damaged.
I'm just going to follow that up. I had a patient in my clinic about 2 or 3 months ago who put it quite nicely. He said, if my knee is wearing out, how come it's twice the size it used to be?
Yeah, yeah.
So the phrase that we generally recommend is if they do say wear and tear and themselves is to try and switch it around to use the phrase wear, flare and repair.
Yeah.
And if you put that slant on it, then you empower them to encourage that repair. So I'll take it on me just to thank Lisa for an excellent talk, and really, really good. Really enjoyed it.
Thank you.